congratulate Merrill on introduction of this device, the BRS, which is really a big challenger for the future angioplasties or the stentings to be done. In fact, this has got multiple advantages over the previous generation of the biovascular scaffold because there is no freezing to be required. It is easily transportable. It is just you take it off the shelf and you have to use it. That's a big advantage. And the most important thing is that as an user for the last several years, covering almost 70 to 80 cases, my experience has been that just follow whatever the guidelines has been prescribed. The PSP is very important. Pre-dilate your lesion very well. Most importantly, a bed preparation is very important. Then you stent it, and after that you post-dilate it. Don't be too aggressive in your post-dilatation because you might fracture the device. That is most important. Imaging, yes, imaging does help. Among imaging, both HT IVUS and OCT can be done. If you're not very sure that you have not deployed it properly, my recommendation would be that if you are a new user, please image it and do it so that you get more used to it, and after all that you can do it in multiple cases. The next take home would be that I at present would reserve these procedures for the younger masses, for arteries which are more than these larger arteries, not for left mains, calcific lesions, and this is a therapy which we have to honor.
Today, speaking especially on thin strut BRS for angioplasty in vulnerable people. We know coronary artery disease is now manifesting even in younger people for probably in their 25 to 45, 50 years age group. And these people are bound to have future events too, because this is not something which is completely curable, but treating the vulnerable period either during an acute coronary syndrome or severe symptomatic stage of the coronary artery disease. The limitation has been treating with metallic stents, what we call regulating stents, that re-interventions when stents fail becomes a challenge because multiple layers of stents may add certain challenges. In that perspective, the reinvention of a thin strut bioresorbable scaffolds, which temporarily scaffold and open the block and disappear over a period of 2 to 3 years, leaving behind no foreign body and allowing the regaining of spontaneous endothelial function, vasomotion, which is proposed to reduce future development of blocks and reduce the events, and also gives the patient and the treating doctor an opportunity to treat the same area of the diseased vessel with another scaffold in the future with maybe lesser event rates. I think towards that, I've had a very good experience of treating about 75 to 80 patients in last 2.5 to 3 years. Unfortunately, most patients are doing very well, and with the added tools which have come in recent decade, that is intravascular imaging with IVUS and especially OCT, which clearly demonstrates the plaque morphology, the scaffold expansion, the lumen dissection. I think this has greatly enhanced the use of BRS in those type A and B lesions, where you can achieve great results matching a regulating stent and giving patients a temporary foreign body and then future treatment options. I think this is the way to go forward.
I would like to reiterate that we have been using BRS stents for the last 3 years and had excellent results, especially in young patients whom we prefer to use them, especially because atherosclerosis is a progressive disease and do not want to have metal in them over the long run in case they require further procedures like surgery or repeat angioplasty in future. And in those who have diffuse disease, what we try to do is use a bioabsorbable stent proximally and use a drug-eluting balloon distally, so that in case repeat revascularization is necessary, they are much better off.